limits the clot size only to the areas of injury. So it is one of a number of protective processes that have evolved in order to maintain a stable physiology, and the intact vascular endothelium is the primary barrier against the hemorrhage. The endothelial cells that line the vessel wall normally inhibit the coagulation and provide a smooth surface that permits the rapid blood flow. So whenever there is a damage to this endothelium, it actually starts the coagulation process and the hemostasis. Intact endothelium is protective against coagulation. Now, what are the steps of hemostasis? Now, as soon as there is an injury or damage to the vascular wall, now what happens? First step is the vasoconstriction. The vasoconstriction occurs and the flowing blood comes in contact with the subendothelial matrix. So, first step is the vasoconstriction. The second step is the primary hemostasis, that in flowing blood, when the flowing blood is exposed to the subendothelial matrix proteins, the von Willebrand factor changes conformation and provides the glue to which the platelet von Willebrand factor receptor, the glycoprotein 1B complex, binds the tethering platelets to the sites of injury. So glycoprotein So glycoprotein 1B is the receptor that is present on the that binds to the platelets, and it is found on the von Willebrand factor. This binding causes the platelet activation and release of storage granules, which in turn leads to platelet fibrinogen binding. And once the platelets are bind to the von Willebrand factor, there is an activation process and there is a release of storage granules from the platelets, and this release of the granules in turn leads to the platelet fibrinogen binding. Now the platelets are activated and their receptor for the fibrinogens are also exposed, and it leads to the platelet aggregation and formation of a platelet plug. This can be seen in this picture, that the first step is the vasoconstriction. As soon as there is a damage to the, or there is vascular injury, causes vasoconstriction, and when there is vasoconstriction, there is the subendothelial matrix exposed, and it leads to the conformational changes within the von Willebrand factor, and the platelets get adhered to the glycoprotein 1B receptors over the von Willebrand factor. And this is the once the platelets are activated, there is exposure of the glycoprotein 2B3 receptor, which binds the fibrinogen, and this fibrinogen leads to the formation of a hemostatic plug or the platelet plug. This is the platelet aggregation. You can see here the platelet aggregation. These are the platelets are activated, and this fibrinogen acts as a glue to bind the different platelets. The secondary hemostasis, one of the subendothelial matrix proteins that are exposed after vascular injury, is the tissue factor. Now, just as exposed subendothelial matrix proteins bind the von Willebrand factor, exposed tissue factor binds to the factor 7 and activates the clotting system. The activated clotting factor that initiates the activation of the next sequential clotting factor in a systematic manner, and we will discuss it in the coagulation pathway. So this is the secondary hemostasis. See this, now here you can see the platelet aggregation leads to a formation of a platelet. Initially there is a platelet plug formation, and ultimately the tissue factor is also exposed, and this tissue factor binds with factor 7 to form the, to activate it, and then causes the activation of the extrinsic pathway. Now, the physiological initiator of the blood coagulation is exposure of the circulating zymogen factor 7 to the membrane-bound tissue factor, and activation of the factor 7 to the protease factor 7 and formation of very high affinity complex of tissue factor with factor 7 results in the activation of factor 10 by the tissue factor 7A complex. You can understand it by this picture. See, this is the extrinsic pathway and this is the intrinsic pathway. Now, extrinsic pathways are whenever there is a trauma, there is release of the tissue factor, and this tissue factor causes the inactivated factor 7 to activated factor 7, and along with the tissue factor 7A activates the factor 10 into factor 10A. And this factor 10 together with factor 5, this is called prothrombinase, and it converts prothrombin into thrombin. So this is the extrinsic pathway. Now what happens in extrinsic pathway? Activation of factor 7 to the protease factor 7A and formation of a very high affinity complex. This tissue factor 7A results in the activation of factor 10 by the tissue factor 7A complex. Now, in the absence of its activated cofactor, factor 5A, factor 10 generates only trace amounts of thrombin from prothrombin. Although insufficient to initiate the significant fibrin polymerization, thrombin formed in this initiation stage of coagulation is able to back activate the factor 5, factor 8, and factor 11 by limited proteolysis. So this is the amplification phase of the coagulation. What happens? You can understand. Now what happens? This factor 10A, which is formed as their activation, as a part of activation of the extrinsic pathway, this factor 10, what it causes the activation of factor 8 to factor 8. And this factor 8 again together with the factor 9 activates the factor 10A, 10 to 10A. So these factors you can see, factor 10, factor 5, prothrombin and fibrinogen, they are the common pathway factors because they are acting in both the extrinsic as well as the intrinsic pathways. While intrinsic pathway starts with whenever there is a damaged surface, factor 12 is activated to factor 12A. Then this factor 12 activates factor 11 and factor 11 to factor 9. Ultimately, factor 8 and factor 9, this is called the tinase complex, and this tinase complex causes activation of factor 10 to factor 10A. And again, factor 10 with factor 5, this is called prothrombinase complex, and it causes prothrombin to thrombin. So this is a bit complicated, but you can understand by this picture. So in the amplification phase of coagulation, factor 11 activates factor 11, which forms a complex with factor 8A. This is the tinase complex that activates sufficient factor 10 to form a complex with factor 5, which I already told you, prothrombinase complex, and this results in the explosive generation of thrombin that ultimately leads to generation of a fibrin clot. Now, how does this, once this coagulation is initiated, there must be an inhibition pathway to limit the coagulation. Okay. So here you can see this is the intrinsic pathway, this is the extrinsic pathway. Ultimately, prothrombin is formed into thrombin, and this thrombin activates fibrinogen into a fibrin clot. Now, this fibrin is a bit friable, and further cross-linking is required to form a strong clot, and this is done by factor 13. So this factor 13 is involved here in the cross-linking of the fibrin clot. So this whole is the coagulation pathway. Now we'll discuss the inhibition pathway. You can see these red lines. These are the inhibiting factors for coagulation. Now, how do they act? Virtually all procoagulant proteins are balanced by an anticoagulant protein that regulates or inhibits the procoagulant function. 4 clinically important naturally occurring anticoagulants regulate the extension of the clotting process. They are antithrombin 3, protein C, protein S, and tissue factor pathway inhibitor. Now, what is their purpose? And you see there are 4 factors which actually act as inhibition of coagulation. Antithrombin 3, as the name indicates, it inhibits the thrombin. It is a serine protease inhibitor that regulates factor 10 and thrombin primarily, and factors 9, 11, and 12 to a lesser extent. When the thrombin in the flowing blood encounters intact endothelium, thrombin binds to the thrombomodulin, its endothelial receptor. And this thrombin thrombomodulin complex then converts protein C into activated protein C. And in the presence of the cofactor protein S, this activated protein C proteolyzes and inactivates factor 5 and factor 8. So factor 5 and factor 8 are inhibited by protein C, and protein S. The inactivated factor 5A is in fact a functional anticoagulant that inhibits the clotting. The tissue factor pathway inhibitor limits the activation of the factor 10 by factor 7 in tissue factor and shifts the activation site of tissue factor and factor 7 to that of factor 9. So you can see at every step of the coagulation pathway, there is an inhibitor available. This tissue factor pathway inhibitor in the factor 7A complex, antithrombin 3 acts on factor 10 and thrombin, then protein C and protein S acts on factor 8 and factor 5. So at every step, there is an inhibitor available which limits the coagulation, and otherwise there explosion of the coagulation, which leads to the formation of the clots everywhere in the body. So we have to there is a pathway that limits the coagulation as well. Now, after having a brief understanding of the hemostasis and the coagulation, now we will come to the clinical side, that how to approach a child with bleeding disorder. So first of all, we have to take the history, and in the history we have to ask the age of the onset, sex of the child, because there are certain disorders that are X-linked recessive, and they affect mostly the males. Then the site of bleeding. Site of bleeding is very much important, like if it is mucocutaneous bleeding or deep muscle or joint bleeding, because it will tell you which pathway of the coagulation or hemostasis involved. For example, in cases of the primary hemostasis pathway, like there is mucocutaneous bleeding, but in cases of if there is a defect or deficiency of the coagulation factor, then there will be the primary the hemostasis plug or the platelet plug is formed, but ultimately the coagulation pathway is not activated and a strong fibrin clot is not formed. So what happens is superficially the bleeding will stop, but the deep muscle or the joint bleeding will continue, like in cases of Hemophillia A and B. Then severity and duration. The severity will tell you how severity. You can ask that how frequent the bleeding is, and is it related to the trauma, or it is spontaneous bleeding. If it is a spontaneous bleeding, that it means that the deficiency is a bit severe variety, and even without trauma, the patient bleeds. If the bleeding occurs only on trauma, it means that the deficiency is mild, and it appears only it appears in clinical notice only when there is trauma. So this will tell you again the severity of the disease. Then history of bruising, hematomas, and prolonged bleeding after surgical procedures. Some disorders are very mild and they only are diagnosed as incidental findings once the patient has gone for a surgical procedure and a routine screening for coagulation defect is performed. After the history, we move to the physical examination, and the physical examination should focus on whether the bleeding symptoms are associated primarily with the mucous membranes or skin, or with the muscles and the joints. Petechiae, chymosis, hematomas, hemarthrosis, or mucous membrane bleeding. Now, in patients who have a positive bleeding history or who are actively hemorrhaging a platelet count, so how do we investigate a child with who is bleeding? The first thing which we'll do is the CBC, platelet count, PT, and prothrombin time, and the partial thromboplastin. They should be performed at once. Now, what is the purpose of performing these tests? The activated partial thromboplastin time is initiated by the addition of a contact activator and test for the deficiencies in the intrinsic pathway. Now you should remember that which factors are involved in the intrinsic pathway. 1, 2, 5, and 10. These are the common pathways. They are involved in both intrinsic and extrinsic pathways. 8, 9, and 11. 8, 9, 11, and 12, these are the intrinsic pathway factors. Then the prothrombin time is initiated by the addition of thromboplastin and phospholipid and test for the deficiencies. This is mistakenly written in the PT, actually test for the deficiencies in the extrinsic pathway. Now, which factors are involved in the extrinsic pathway? 1, 2, 5, and 10, they are the common pathway, they are involved in both. Factor 7 is the extrinsic pathway factor. 1, 2, and 5, 10, as I already mentioned, are the common pathway, and their deficiency leads to prolongation of both PT and APTT. So here we must understand that in cases of deficiencies of factor 8, 9, 11, and 12, there will be prolongation of only APTT. In cases of deficiency of factor 7, there is prolongation of only PT. And in cases of deficiency of any of the factors of the common pathway, that is 1, 2, 5, and 10, there will be a prolongation of both PT and APTT. Now, what is the bleeding time? The bleeding time assesses the function of the platelets and their interaction with the vessel wall. And although the platelet count of less than 1 lakh are associated with prolonged bleeding time, disproportionate prolongation of bleeding time may suggest a qualitative platelet effect. So sometimes what happens that the platelet count is normal, and still the bleeding time is prolonged. So it means there is a qualitative defect or a functional defect within the platelets, and which is seen in certain platelet function disorder as well in the von Willebrand disease. So bleeding time is also important in the diagnostic workup of a bleeding child. Then comes the platelet aggregation studies. When a qualitative platelet function defect is suspected, platelet aggregation testing is usually ordered, and the platelet-rich plasma from the patient is activated with one of a series of agonistic ADP, epinephrine, collagen, thrombin, and thrombin receptor peptide, and histocity. So this will tell you about the functional defects in the platelets. And the platelet count is normal, but the platelets are not functional. So this is a list of the common bleeding disorders which we are going to discuss today. And among the inherited bleeding disorders, we have Hemophillia A, Hemophillia B, and von Willebrand disease. Then there are rare bleeding disorders in which there is factor 5 deficiency, factor 7 deficiency, and the factor 10 deficiency. Platelet function defects like Bernard-Sorier disease and the Glanzman thromboasthenia. You see there is a long list of the platelet function disorders, but these are the two most common types. And in the acquired, we have the idiopathic or the immune. Idiopathic is no more idiopathic, it's basically the immune thrombocytopenic. What is hemophilia? Hemophilia A. Hemophillia A is the occurs because of the deficiency of the factor 8, while hemophilia B results from the deficiency of factor 9. And these are the most common in the serious congenital coagulation factor deficiencies. And the clinical findings in hemophilia A and hemophilia B are virtually identical. So clinically, we cannot differentiate between hemophilia A and B. So hemophilia C is the bleeding disorder associated with reduced levels of factor 11, and it is a very, very rare disorder. A and B are pretty common, but the C is very rare. And hemophilia A and B both are X-linked recessive disorder, while hemophilia C is the autosomal recessive disorder. So it is also called autosomal hemophilia. So what do you mean by X-linked recessive disorder? Is these are the disorders which mainly affect the males, and but sometimes the females may also be affected, like if one of the X chromosome in the female is becomes non-dominant, like in the lionization phenomena or in Turner syndrome, in which one of the X is missing, then in these cases this disorder is manifested clinical, results in clinical bleeding. Otherwise, females are usually the carriers, and the disease manifests only in the males. While hemophilia C is the autosomal recessive, and it affects both males and females equally. Hemophilia occurs in approximately 1:5,000 males, with 35% having factor 8 deficiency and 10 to 15% having factor 9 deficiency. Now, in hemophilia A or B, clot formation is delayed and is not robust. Inadequate thrombin generation leads to failure to form a tightly cross-linked clot to support the platelet plug, and patients with hemophilia slowly form a soft friable clot. When untreated, bleeding occurs in a closed space such as a joint. Cessation of bleeding may be the result of tamponade. It can present in fetal life and early infancy. 2% have intracranial bleed and 30% have bleeding on circumcision. Obvious symptoms such as easy bruising, intramuscular hematomas, and hemarthrosis begin when the child begins to crawl. Although bleeding may occur in any areas of the body, the hallmark of hemophilia bleeding is hemarthrosis. Bleeding into the joints may be induced by minor trauma, and many hemarthroses are spontaneous. So, it depends on the severity of the disease. If the factor level is reduced to less than 1% or the severe variety, then spontaneous bleeding can also occur. But in mild cases, bleeding occurs only on trauma. The earliest joint hemorrhages appear most commonly in the ankle. So ankle is the most commonly affected joint in cases of hemophilia. Now, diagnostic workup, as I already mentioned, since it is a intrinsic pathway factor, so it leads to the prolongation of the APTT. And once we get the report of prolonged APTT, and we are suspecting hemophilia, we will send the specific factor assays. Since clinically we cannot diagnose whether it is factor hemophilia A or B, so we send the factor 8 and the 9 levels simultaneously. Or we can do it one by one depending on the feasibility and the patient's financial status. Now, the classification of the hemophilia on the basis of the factor level, that is, severe hemophilia is characterized as having less than 1% activity of the specific clotting factor, and here the bleeding is open spontaneous. So, the bleeding happens even without trauma. Moderate hemophilia having a factor level of 1 to 5% and usually require mild trauma to induce bleeding, and mild hemophilia, the levels are more than 5%. It may go many years before the condition is diagnosed and frequently requires significant trauma to cause the bleeding. So, they are the cases which are usually late, they present very late, and sometimes they present on a routine diagnostic workup for a surgical procedure or any other illness. And the hemostatic level for factor 8 is 30 to 40%, and for factor 9 is more than 25 to 30%. Now, what do you mean by hemostatic level? Hemostatic level is the, you see, when we measure the factor activity, we take the 100% as the normal. But 100% activity is or the level, factor level is not always present. So, there is a level of the of each factor at which the hemostasis is achieved, and this is the minimum level which is required to achieve the hemostasis. This is called the hemostatic level, and for factor 8 it is 30 to 40%, and for factor 9 it is 25 to 30%. And the lower limit of the levels for factor 8 and factor 9 in normal individuals is approximately 50%. So if it is when we will diagnose as a case of hemophilia, if the factor activity is less than 50%. Now, how are you going to treat? Early appropriate therapy is the hallmark of excellent hemophilia care, and mild to moderate bleeding occurs. Values of factor 8 or factor 9 must be raised to hemostatic levels in 35 to 50% range to prevent the prolonged bleeding and further complications. Calculation of the dose of the recombinant factor 8 of factor 9 is as follows. For factor 8, the formula is desired rise in factor 8 multiplied by body weight multiplied by 0.5. This 0.5 is the constant for factor 8 and 1.4 is constant for factor 9. And the desired rise in factor 8 is the factor level which we need to control the bleeding. Like in cases of mild like joint bleeding or any other bleeding, the range is 35 to 50%. So we will require 35 to 50% rise in the factor. But there are certain conditions in which we need the more than 80 to 90% of the factor levels, like in cases of major surgeries, head and neck surgeries, or any major trauma or CNS surgeries, we require in which there is a high risk of bleeding, like bypass surgeries. So here we need the higher level factors for hemostasis. So based on the desired rise in the factor 8, we can calculate the dose of the factor 8. So these factor 8 are the synthetic factor levels which are available in the market. So these are the specific therapies for hemophilia. But what if whenever a patient comes to the emergency, he is bleeding, and you don't know what is the cause of the bleeding, then you will get the prolongation of the PT or the APTT, but factor level assay requires time, sometimes 3 to 4 days to diagnose the factor level deficiency. So meanwhile, what you have to do, we'll give the fresh frozen plasma, because plasma contains all the clotting factors. So empirically, when we don't know the diagnosis and the patient comes to you with bleeding, and you know that the platelet count is normal and this patient has a clotting factor deficiency. Now, which clotting factor, we don't know, but there is the clotting factor deficiency, then empirically, to control the bleeding, you can give the fresh frozen plasma. With mild factor 8 hemophilia, the patient's endogenously produced factor 8 can be released by the administration of the desmopressin acetate. This is a desmopressin acetate. What it causes? It causes the vasoconstriction. And in mild cases of hemophilia, what happens that since the bleeding is usually not very severe, and the factor levels are also there, they are present within the body. So what we do, we give the desmopressin acetate, and this desmopressin acetate causes the vasoconstriction, and vasoconstriction causes the release of the stored factor 8 from the 1 Willebrand factor, and it's released into circulation, and factor levels can be raised and the bleeding can be controlled. But it doesn't work in every case, but most of the time in mild hemophilia, it works. So basically, see, in hemophilia, we discussed 3 types of therapies. Empirically, we will give fresh frozen plasma. Mild cases where we can give DDAVP or the desmopressin acetate. It comes in the form of nasal spray as well as IV form, but we usually recommend nasal sprays. And the definitive treatment is the factor replacement therapy, factor 8 or factor 9. Now, what is the prophylaxis? The National Hemophilia Foundation recommends that prophylaxis be considered optimal therapy for children with severe hemophilia. Usually, such programs are initiated with the first joint hemorrhage, and such programs are expensive but are highly effective in preventing or greatly limiting the degree of joint pathology. Now, what is the purpose of giving prophylaxis? Prophylaxis means that in cases of severe hemophilia, what happens? The bleeding occurs spontaneously, and you don't know whenever the bleeding happens. So, to prevent that spontaneous bleeding, now why do we give the prophylaxis factor replacement therapy? To keep the plasma factor level of 1 to 2% all the time, and we give the factor 8 or factor 9 2 to 3 times per day, depending on the type of regime which we are following. Now, why it is important? Why do we give this prophylaxis? The reason for this is that multiple hemorrhages within the same joint leads to the joint damage, and ultimately it will increase the morbidity of the child. The child can become the bedbound or immobile, and joint destruction happens. So to prevent this target joint and the formation of the joint pathologies, as well as to improve the quality of life of the patient, this prophylaxis therapy is very, very important, and it should be initiated after the first joint hemorrhage. But remember, this is done in cases of severe hemophilia, not in the cases of mild to moderate, in which the bleeding happens only after trauma. This is to prevent the spontaneous bleeding. The treatment is usually provided every 2 to 3 days to maintain a measurable plasma level of clotting factor when assayed just before the next infusion. So that's all about hemophilia. Now we'll discuss the briefly about the von Willebrand disease. The most common hereditary bleeding disorder is von Willebrand disease, and some reports suggest that it is present in 1 to 2% of the general population. It is inherited autosomally, but most centers report more affected women than men. Because menorrhagia is a major symptom, women may be more likely to seek treatment and thus to be diagnosed. It is classified again on the basis of whether the protein is quantitatively reduced, qualitatively reduced, or absent. So there are 3 types. One is a quantitative defect in which the factor level is present, but it is reduced. This is type 1. Then second one is the qualitative or the functional defect in which the factor levels are normal, but it's non-functional. And the third is a type 3, which is a severe form of von Willebrand disease in which the factor, non-Willebrand factor is absent, it is less than 1% or undetectable. It's the most severe form of von Willebrand disease. Most common is the type 1 and followed by type 2, and then type 3 is the rarest form. The von Willebrand factor is stored in the platelet alpha granules and endothelial cell web in platelet bodies during normal hemostasis. As I already mentioned, that the von Willebrand factor adheres to the subendothelial matrix after the vascular damage, and when von Willebrand factor binds to the subendothelial matrix, the conformation of the von Willebrand factor is altered by shear so that it causes the platelets to adhere to the von Willebrand factor through the glycoprotein 1b receptor. Now, one thing which I mentioned here, that this glycoprotein 1b receptor, its deficiency again leads to the platelet function disorder, which we'll discuss later on. Von Willebrand factor also serves as a carrier protein for plasma factor 8. This is a very important point, that whenever there is a von Willebrand disease, since von Willebrand factor acts as a carrier protein for the factor 8, once the factor von Willebrand factor levels are reduced, the factor 8 levels are also reduced. So, for when we treat the patient, we have to give factor 8 along with the von Willebrand factor to control the bleeding. The patients with von Willebrand disease usually have symptoms of mucocutaneous hemorrhage, including, since it is involved in the primary hemostasis, so the patient presents with superficial or the mucocutaneous bleeding, including excessive bruising, epistaxis, menorrhagia, and postoperative hemorrhage, particularly after mucosal surgery such as tonsillectomy or wisdom tooth extraction. Because von Willebrand factor is an acute phase protein, stress will increase its level. Thus, patients may not bleed with procedures that incur major stress, such as appendicectomy and childbirth, but may bleed excessively at the time of cosmetic or the mucosal surgery. Although patients with von Willebrand disease were described historically as having a long bleeding time and a prolonged partial thromboplastin time, these findings are frequently normal in patients with type 1 disease. And because there is no single assay that has demonstrated the ability to rule out von Willebrand disease, if the history is suggestive of mucocutaneous bleeding disorder, von Willebrand testing should be undertaken, including a quantitative assay for von Willebrand antigen, testing for von Willebrand factor activity, and testing for plasma factor 8 activity and a platelet count. So whenever you are suspecting von Willebrand disease, you just don't go for the von Willebrand factor assays. We have to check the factor activity, factor level, factor activity, as well as the factor 8 levels to make a complete diagnosis of the von Willebrand disease. But the treatment again, empirically, when you don't know the diagnosis, you just have a prolonged bleeding time, you just have a prolonged partial thromboplastin time, you can give fresh frozen plasma. But once you know the diagnosis, again for mild cases in which that bleeding appears only after trauma or the type 1 von Willebrand disease, we can give desmopressin acetate, because again it causes vasoconstriction and the release of the von Willebrand factor from the endothelium, and the factor level can be raised. But in moderate to severe cases and in cases of acute bleeding, you have to give the factor replacement therapy. A small subset of children and especially infants do not release von Willebrand factor and is exposed to desmopressin. In these cases, replacement therapy must be used. Current replacement therapy uses plasma-derived von Willebrand factor containing concentrates that also contain factor 8. So the von Willebrand factor as replacement therapy that is available currently also contains the factor 8. As I told you that it acts as a carrier protein for factor 8. So for the treatment, we need replacement of both factors. Now we should discuss the platelet function disorders of Bernard-Soulier disease. Is an autosomal recessive disorder. It is a severe congenital platelet function disorder, and it is caused by the absence of severe deficiency of the von Willebrand factor receptor on the platelet membrane. This syndrome is characterized by thrombocytopenia with giant platelets and markedly prolonged bleeding time. Now, you see the platelet count are normal, or sometimes there is mild thrombocytopenia, but the bleeding time is markedly prolonged. Once the bleeding time is prolonged and the platelet count is normal, to assess the platelet function defect, we go for the platelet aggregation test, which show absent histocity-induced platelet aggregation but normal aggregation to all other organs. Now, how these platelet aggregation tests are performed, that we add certain reagents and then we check the platelet activation, So, and then the aggregation. So, in case of the case of Bernard-Soulier disease, what happens is the platelet show aggregation to all other organs except, but the aggregation is absent on the histocity. So histocity induces the binding of von Willebrand factor to the platelets and agglutinates the platelets. Those are results of the von Willebrand factors. These are normal. In mild bleeding, desmopressin may be effective. Severe bleeding requires platelet transfusion. Bone marrow transplantation is curative, but is very expensive and very complicated procedure. So usually we don't go for the bone marrow transplant. It's still under trial process. Second one is the Glanzman thromboasthenia. It is a congenital disorder associated with severe platelet dysfunction that leads to prolonged bleeding time and a normal platelet count. This disorder is caused by the deficiency of the platelet fibrinogen receptor. You can understand this by this picture. You see here. The Bernard-Soulier occurs because of the deficiency of this glycoprotein 1b receptor, which is present on the platelets, and it binds to the von Willebrand factor. While Glanzman thromboasthenia is again caused by another receptor, which is again lying on the platelets, glycoprotein 2b3a complex, and it binds the fibrinogen. This is the fibrinogen. Okay. So this is the difference between the two. 1b binds to the von Willebrand factor, while 2b3a binds to the fibrinogen, and both are involved in the platelet aggregation. Aggregation studies show a normal or absent aggregation with all agonists used except histocity, because histocity agglutinates the platelets and does not require a metabolically active platelet. So it is the results are against that seen on the Bernard-Soulier. Again, treatment is same, desmopressin in the platelet transfusion, and the curative treatment is bone marrow transplantation, which is still under trial and it's not performed routine in this disease. After the inherited disorder, now we come to the acquired disorder, idiopathic or the immune thrombocyte. It is no more idiopathic, it's a misnomer, and now we call this immune thrombocytopenia because we know that it is an immune disease. The most common cause of acute onset of thrombocytopenia in an otherwise well child is autoimmune or thrombocytopenia purpura, and it is characterized by a recent history of viral illness. In 50 to 65% of the cases, the peak age is 1 to 4 years, although the age ranges from early infancy to elderly. In childhood, males and females are equally affected. And ITP seems to occur more often in late winter and spring after the peak season of viral respiratory illness. Now, why it is linked to the viral respiratory illness is that what happens in the body that we have an immune system that forms the antibodies against any viral illness which we get. And sometimes, unfortunately, what happens is the antibody, because of an immune dysfunction, the antibodies that are formed against these virus or any pathogen, they cross-react to the patient's own platelets and causes destruction of these platelets. So, it is an autoimmune disorder, or the immune dysfunction is there, which causes destruction of the body's own platelets. And this results in the immune thrombocytopenic purpura. Most common viruses that have been described in association with ITP include the Epstein-Barr virus and the HIV. Epstein-Barr virus-related ITP is usually of short duration and follows the course of infectious mononucleosis, while HIV-associated ITP is usually chronic. In some patients, ITP appears to arise in children infected with H. pylori or rarely following the measles, mumps, and rubella vaccines. So, apart from the active infection, viral vaccines can also initiate the ITP. The clinical features, the patient can have no symptoms, just there is thrombocytopenia on the lab report. Patient can have mild symptoms of bruising and petechiae, occasional minor epistaxis, very little interference with the daily living. In the moderate cases, more severe skin and mucosal lesions, more troubles and epistaxis and menorrhagia. In the severe cases, bleeding episodes of menorrhagia, epistaxis, melena, requiring transfusion or hospitalization, and symptoms interfering seriously with the quality of life. The presence of abnormal findings such as hepatosplenomegaly, bone or joint pain, or remarkable lymphadenopathy suggests the other diagnosis. Now, how are we going to diagnose? If there is severe thrombocytopenia, the platelet size is normal or increased, reflective of increased platelet count. ITP or the immune thrombocytopenia is basically a diagnosis of exclusion. And there are a lot of disorders in which the thrombocytopenia is present, like leukemia, and so we have to rule out the acute conditions or life-threatening conditions. Like, first of all, we have to rule out the infections like malaria or dengue. Then we have to rule out the malignancies like leukemia, acute leukemias. And for that, we will take a good clinical history and examination, followed by other peripheral findings. And if we find any abnormal finding, because the patients with ITP are usually clinically well, they don't have any viscerally or lymphadenopathy, they are usually afebrile, and they are otherwise clinically well, except that they have petechiae and bruises or any bleeding symptoms. Otherwise, they are well. These are the well child, which have no other symptoms except the minor bleedings. But if we get any abnormal finding, there is any hepatosplenomegaly or lymphadenopathy, or if the child is febrile or sick looking, then in these cases, we will go for the further diagnostic workup, extensive diagnostic workup, as well as the bone marrow examination. In cases of ITP, though bone marrow is usually not performed, but if we do it to rule out any other illness, bone marrow examination shows normal granulocytic and erythrocytic series with characteristically normal or increased number of megakaryocytes. So the increased megakaryocytes is the hallmark of the ITP on the bone marrow biopsy. And why these megakaryocytes are raised? Because of the increased platelet turnover. Because there is peripheral destruction of the platelets, the bone marrow is hyperactive, and the megs are increased. Megakaryocytes are increased. Now, the indications for the bone marrow, as I already mentioned, include an abnormal WBC count or differential unexplained anemia, as well as findings on the history and physical examination suggestive of a bone marrow failure syndrome or malignancy. Treatment may, for patients who are asymptomatic or mildly symptomatic, no therapy other than education and counseling of the family and patient for patients with minimal, mild, and moderate symptoms. IVIG is given at a dose of 0.8 to 1 gram per kg per day for 1 to 2 days, induces a rapid rise in platelet count in 95% of the patients within 48 hours. Intravenous NTD therapy for Rh positive patients, IV NTD at a dose of 50 to 75 microgram causes a rise in platelet count to more than 20 in 80 to 90% of the patients within 48 to 72 hours. Now, what is the purpose of giving this NTD therapy? This NTD therapy is given only in the Rh positive cases, and the purpose of giving, or the rationale of giving this NTD, is that it diverts the immune system towards the hemolysis of the red cells, and the platelets are saved. The third option is the prednisolone. Corticosteroid therapy has been used for many years to treat acute and chronic ITP in adults and children. And doses of prednisolone of 1 to 4 milligram per kg per day appear to induce a more rapid rise in platelet count than in untreated patients. And the platelet usually turns to show response after 4 to 5 days. The second line drugs include thrombopoietin receptor agonists like altrombopac. Splenectomy is reserved for refractory cases. Prognosis in 70 to 80% of the children who present with acute ITP, spontaneous resolution occurs within 6 months. And the persistent ITP is the one which lasts for 6 to 12 months. And chronic ITP is the one which is lasting for more than 12 months. So in cases of chronic ITP, we will go for the second line drugs and splenectomy in refractory cases. Now the summary. Hemostasis is characterized by primary and secondary pathways, and it involves formation of a stable clot along with control of excessive coagulation via specific inhibitors. Coagulation cascade includes extrinsic and intrinsic pathways, however, both operate simultaneously. Hemophillia and the Willebrand disease are the commonest hereditary bleeding disorders in children. Thorough history and proper clinical examination are important in making the early and the proper diagnosis. And the management includes the use of blood products in emergency and appropriate factor replacement therapy once the diagnosis is established. ITP is a benign childhood platelet disorder with good prognosis in 70% of the cases. So now I have ended with the lecture, and if you have any questions, you can ask me, as we have 9 to 10 minutes left. And one thing which I want to mention, which I have not included in the lecture, is that whenever a patient is being diagnosed as a case of bleeding disorder, we have to counsel the family. Counseling is very much important, and for children especially, we have to counsel the parents that they should avoid the high-risk behaviors. So what is the high-risk behaviors? That the sports which leads to the trauma, like football, cycling, and you can, in cases of mild cases, you can continue with these sports, but you have to take the protective measures, like extra paddings or for cycling or any other riding. So high-risk behavior should be avoided. Anti-D therapy causes mild hemolytic anemia because we are giving a very low dose. So it's basically is given to divert the immune system toward it causes the saturation of the FC receptors of the immunoglobulins, and some degree of hemolysis is there. Some degree of hemolysis do happens, and we have to monitor the HP level whenever we give the anti-D therapy. But usually the hemolysis is mild and we get only mild degree of anemia. But it is very effective sometimes in controlling the platelet destruction. And this therapy will only work in the Rh positive cases, and it won't work in Rh negative patients because the red cells, it won't work in the Rh negative patients. I hope that you understand. Okay. Vistostatin is basically a laboratory chemical which we used in laboratory, as I mentioned, that in platelet aggregation studies. How do we measure the platelet aggregation? We use certain reagents like vistostatin, epinephrine, ADP, and there are certain other reagents to see the platelet aggregation. Now, vistostatin is the one of the chemical that initiates the coagulation whenever the von Willebrand factor receptor, that is glycoprotein 1b, is present. So in cases of Bernard-Solier, the vistostatin induced platelet aggregation is absent. It is basically a lab parameter. In laboratory we use it, but when you see the reports, you see this is written that the aggregation against the vistostatin is absent, which means that the glycoprotein 1b receptor is absent, which is required for the vistostatin induced platelet aggregation. So it is basically a lab chemical or reagent that is used in the laboratory to diagnose the platelet aggregation. It has nothing to do with the coagulation pathway. Spontaneous bleeding can occur in any of the disorder, whether it is a clotting pathway defect or it is thrombocytopenia. It basically depends on the severity of the defect. Like in cases of ITP, some cases are severe and the spontaneous bleeding do happen. Even in thrombocytopenia as well as in hemophilia. So it has nothing to do with the type of defect. It is basically the severity of the defect which leads to the spontaneous bleeding. The more low the level of the factor or the platelet count, the more marked is the bleeding. Hemophilia is a very common disorder, and when you work in a when you come to the practical or the clinical site, you can see there is a Hemophilia Federation of the Pakistan, or Hemophilia societies are made. So we have a pretty high number of cases of hemophilia. So it's pretty common. Bleeding disorders. The commonest, these all are the commonest bleeding disorders which we come across in our daily practice. Hemophilia is very common. Hemophilia A is more common than hemophilia B. In Pakistan, hemophilia A is very much common. Like you can say that if we have 100 cases of hemophilia, then around 80 are of hemophilia A, that is factor 8 deficiency, and only 20 will be of the hemophilia B. So A is more common than B. We have 2 to 3 minutes left. If you have any questions, you can ask. Okay, what is cryoprecipitate? Okay, cryoprecipitate is a part of the plasma. You see, whenever we take blood from any donor, we divide into 3 components. One is the packed red blood cells, second one is the platelets, and the third one is the plasma, or which we call the fresh frozen plasma. Now, this fresh frozen plasma contains all the clotting factors, including from factor 1 to factor 12, as well as protein C, protein S. So it contains all types of factors. Now, when we centrifuge this plasma, fresh frozen plasma, further, then we have 2 components. 2 components are further formed from this fresh frozen plasma after centrifugation to a certain frequency. And after centrifugation, we get 2 parts. One is the cryoprecipitate, the precipitates which are settled on the bottom, which is called the cryoprecipitate or the CP. And one is the cryosupernatant fluid. Supernatant fluid and the precipitate. These 2 are formed after centrifugation of the fresh frozen plasma. Now, what is the difference between these 2 is that certain factors after centrifugation, they are left in the bottom and they form the cryoprecipitate, which includes the factor 1, factor 13, von Willebrand factor, and the factor 2. These 4 factors are found in the cryoprecipitate. So it is basically a concentrated form of these factors, and it can be used as a replacement therapy for treatment of the diseases in which these factor deficiencies are present. Like this cryoprecipitate contains factor 1 or the fibrinogen. It also contains von Willebrand factor. It also contains factor 8 as well as factor 13. So in these factor deficiencies, if the factor replacement therapy is not available or we cannot use because of the financial reasons, because these factors are very expensive, so cryoprecipitate can be used in place. It is basically a concentrated form of these factors and it's a part of the plasma. While the cryosupernatant, which is formed as a supernatant fluid, contains other proteins, antibodies, as well as the factor 9 and other factors. So this is basically a part of the plasma. I hope you understand the point. So now the time is up, and thank you so much. I hope that you will get all the points. And, okay, Allah Hafiz. Okay, Mr. Saqib, I am leaving the meeting.